All right, guys. So
We're going to get started.
Welcome to Exporting Your Ideas, How to Adapt Your Curriculum for Use in Different National Contexts. This is the ever-present, incredible Julie
Hello.
Rice.
Hello. We have to speak into mics because they're recording. I just want to let you know this is not performative for peak awkwardness. We're being forced to do this.
Yes. So Julie is an assistant professor at the Johns Hopkins Hospital. She's the director of our, I formerly worked there, so I say our still. Director of the Residency Simulation Program. She's also affiliate faculty at the Armstrong Institute for Patient Safety.
And this is the great Eisha Chopra. She is currently at Thomas Jefferson. She left me for another hospital. She is a clinical assistant director in the Department of Emergency Medicine and an all-around badass in teaching, simulation, psychologically safe environments, and just being kind of an awesome mentor.
I promise we'll do a serious talk for you. So we don't have any relationships or competing interests to disclose. Oh, I wrote to close. All right, well, to disclose.
We have no disclosures. We are not that cool.
Yes. So we're going to talk about a couple of things in the brief time that we have together. So we're going to discuss the importance of adapting educational curricula for use outside of the original national or cultural context in which it was actually developed. And we're going to first look at some lessons from aviation, cross-cultural psychology, and public health, which really kind of distill down why it's important to consider this when you're doing curriculum adaptation. We're going to describe a 4-stage model for curriculum adaptation. And then we're going to show you guys a real-life example where we modeled this when we adapted a TeamSTEPPS training program, which is, if you guys are not familiar with it, it's a program that was developed in the United States in order to optimize like interprofessional team performance in high-risk situations. And we adapted that in Beirut, Lebanon.
Yeah, so are you guys familiar with TeamSTEPPS? Have you ever heard of TeamSTEPPS? Heard of it. Okay, so just the 30-second version, it started actually in aviation, and we're going to talk about that in a second, but it started in aviation where they made something called cockpit resource management, which later became crew resource management. And this taught teams that had a hierarchy, like a pilot and a staff and kind of their ancillary plane staff and their maintenance crew. It taught them how to work together so that you had a safer environment so that you could have a shared mental model, better communication techniques, and it's all about making a safer environment. So that was then adapted by anesthesiologists for the use in medicine, and emergency medicine just like grabbed it and was like, oh, we would love this too. When you implement TeamSTEPPS, now it has been implemented, it has been translated into 35 languages. It is all over the world. It's fairly ubiquitous. And I have helped implement this in a few different hospitals in the United States between medical school and residency. And then I was asked to implement it in a hospital in Beirut, Lebanon. And I thought, oh yeah, I've done this a few times before. So the first part of it is that you do something, there's 3 phases. The assessment phase where you do a readiness survey. And it's supposed to be, is this culture in this place ready for training like this? Because if you have really huge problems or people that are like tyrannical and controlling, you might not be able to implement TeamSTEPPS that well because that's not going to break that culture. So the culture needs to be a bit primed and ready. Phase 2, you do a planning, implementation, and then phase 3 is you sustaining what you've done, maybe doing retraining, maybe collecting data, giving feedback. So this 3-phase model is fairly, it's used in a lot of different curricula, but TeamSTEPPS always uses this. Now, you'll see here it says culture survey and are you ready? But when we did this in Beirut, we asked ourselves, well, wait, they're ready, but is this training appropriate? Like, this was made in the United States. Is this now going to be appropriate? Because maybe there are some important cultural differences. And some of my work in the emergency department there, I thought people really interact differently here. And should I just blanket over all of that difference with this training that I've done before, or should we really be acknowledging those differences? I'm a fairly liberal person, so I thought, yeah, those differences should be acknowledged and we probably should account for them. So, in thinking, is it important to consider culture? I thought, well, who else has considered culture? Going back to aviation where TeamSTEPPS started, we Again, aviation had started with cockpit resource management, crew resource management, and it turns out this was in response to the 1977 Tenerife air disaster. It's still considered the worst aircraft disaster in the history of aviation. 2 large jetliners crashed into each other at takeoff, going towards each other on a runway, and it was because of a communication issue. It turns out everybody in the cockpit knew what was about to happen, but nobody spoke up to the pilot, and a lot of people died. So in response to that, that's when they started saying, you know what? There needs to be some sort of training. We need to have speaking up behaviors. People need to feel empowered, and leaders need to be primed to listen. So when that started to be worked into a training program and implemented, suddenly the FAA said this needs to happen everywhere in the US. The United States had much better performance on safety for aircraft than the rest of the world. That made the International Aviation Association say, ooh, we want to do this too. And they took CRM, crew resource management, and they implemented it everywhere. And suddenly they saw problems because the things that were being taught in the United States, Malcolm Gladwell writes about this in some of his books, but when they tried to, the example he uses, when they try to put it into South Korea, the way that people communicate are different, and you can't use the same training to modulate behaviors in the Western context as in this other cultural context. So when implemented internationally, they're having problems. So Robert Heimlich and Merritt, you can see that there's been whole books written about this. And you're going to notice the title of the book. This is like an older book, you can tell from the cover. It says aviation and medicine. So people have actually thought about this before and cross-translated it. One of the interesting things I found in this book was they did this huge survey, 15,000 pilots, 23 different countries. And they actually found that there was these 6 clusters of countries with similar responses for work values. So they actually made these 6 different clusters. And then they modulated the training for CRM so that it was more congruent with those 6 different patterns. And that's actually how they overcame the differences. But there was a lot of analysis of those 6 different patterns. Now, you don't want to put anybody into a box, so these are generalities, but it really helped when they were trying to implement this globally. They found that the national culture differences most impacted areas command, endorsement of rules, and attitudes towards automation. Now, those things are probably going to be important in medicine, right? You think about the emergency department, automation, AI is coming, still very important. Now, all of these things are really accounted for when they're teaching safety programs in aviation.
But beyond aviation, we can see that this has actually been accounted for in different disciplines as well. So one is in cross-cultural psychology. So in 1997, there was this development of a theory of equivalence, and the idea is that when you are trying to implement a test or an intervention, you have to actually see that there's an equivalence in the target culture compared to the culture in which that initial test was actually developed. Otherwise, like when we look at research studies, right, you're looking to see, can the outcomes from the study actually be applied to my community or my patient population? It's the same idea when you're implementing any kind of like interventions or tests, even in other disciplines. And aside from that, there were also these models of national cultures that were developed by both Hofstede and Gelfand that we'll briefly talk about, just looking at these different kinds of shared values or shared norms that when you examine different cultures do become apparent, similar to the study that came out that the aviation industry did. So Hofstede came up with all these different dimensions. He called them things like power index. Is this community more individualistic or collectivist? Tends to lean more masculine or feminine? Are they more indulgent or more restrained societies? The two that we found interesting that really we thought could translate to medicine and were important to medicine were specifically the power index, which is the idea that can a subordinate, like how much does a subordinate feel the power difference between them and their superior? And that's obviously important when you're in environments where you rely on people that may be in subordinate positions in order to speak up, discuss mistakes, and generally be honest in order to avoid impacts on patient care or errors, right? Similarly, uncertainty avoidance, the idea that society's tolerance for ambiguity or uncertain situations may be more or less. again, emergency departments. All we deal with, right, is uncertainty about things. We operate from the perspective that we don't know anything that's going on, but there's lots of societies that generally feel uncomfortable being put in those types of situations. So having a sense of that and examining those things when you're looking at a culture before implementing an intervention can be important.
And I'm just going to say for a second,
Yeah.
all of these psychological models are very controversial. There's whole conferences based on like whether or not these are real things. But in looking at it, there's been a lot of work in this area. And so what we were taking away from it was, I think somebody's saying that there are tendencies and differences, and they seem like they would really impact the areas that we wanted to train in. So,
Absolutely.
so definitely nothing to memorize.
Yeah, and another big school of thought comes from Gelfand, and the idea, again, this idea of like tight and loose cultures, and that there are cultures that adhere very strongly to their social norms and what they portray and what they live in their daily life, as opposed to looser cultures that maybe are more comfortable with individual deviations from like what's considered standard behavior and things like that. And again, you can imagine that before you're going to implement an intervention into a culture, it's important to actually know, like, is this a culture you're going into where everyone's going to want to follow the plan that you're trying to implement by the book, by the letter, or maybe this is a culture where they feel like, this is kind of like guidelines that we should adhere to, and maybe we can people can take their own interpretation.
Go back, you skip.
What? I skipped one. Oh, sorry. This is kind of advancing on its own. And then lastly, public health has also been doing research in this, like far beyond,
Yeah,
even
they
medicine
take
before.
things and they put them in other places all the
Yeah,
time.
exactly.
So what are they doing?
And this staged model for evidence-based public health initiatives is actually what we looked to when we came up with our initial intervention plan and our 4-stage model. So we'll touch on that a little bit more as we go on. But again, this is all just to highlight that outside of medicine, lots of different disciplines have already been looking into this. And when we examined it, we're like, yeah, duh, this seems really obvious, but why haven't we actually been doing this more? Because it seems so critically important to the culture in which you're trying to implement an intervention.
Yeah, we looked up, TeamSTEPPS has been implemented, again, 35 different languages all over the globe. Nobody's ever published. We did it somewhere else, and this is how we adapted it. Unbelievably. So yeah, so how should we account for national culture when adapting our initiative? First of all, I'm going to say, before I get to our 4-stage model, you have to have the right mindset and you have to be proactive. You have to go into the situation emphasizing that no culture is right or wrong. Coming into my work in Lebanon, a lot of people said, we're sick and tired of people from Hopkins or Cleveland Clinic or whatever coming over and saying this is the right way to do it. And I was like, I am not here to say that. So no culture is right or wrong. You have to start that mindset at the beginning, and you need to emphasize that. And new behaviors are tools in your toolbox. They are not correct behaviors. So you don't come in and say, this behavior that you're doing is incorrect. You can say, closed loop communication is a tool that you can use to make sure that your communication is clear and received in the way it was intended. It is a tool in your toolbox. So that's first. Next, we get to the 4-stage model. So just like with public health, you have, this is kind of the language we came up with, assess construct equivalence, do the preliminary adaptation, do the preliminary adaptation, adapt or pilot that adaptation, and then you do a final content adaptation and trial. And it kind of circles back through again and again as you're going to learn more. So first, Eisha's going to talk about what we did first.
Yeah, so first was, again, assessing that construct equivalence. So we started by doing a data-driven cultural assessment. This was primarily through the use of surveys, both quantitative and qualitative, in our target group. So we did interviews, we gave more like specific written surveys in the target group before we even started to look at what would need to be modified.
Group and individual interviews. We did a lot of qualitative analysis.
And then we also reviewed the literature on the topic. Like Dr. Rice said, she went and looked, and there's nothing published about like how TeamSTEPPS or other similar models have ever been adapted into different cultures. And then we performed an analysis of those surveys to look at the relevant themes between the context of origin, which in this case was the United States, and then the target context, which here was Beirut, Lebanon. And then, again, we reviewed what little published there was about the adaptation.
Yeah, and when we say relevant themes, and this it was like, what does safety culture mean to you? Do you know what closed loop communication is? And we took a map of all the themes in TeamSTEPPS, and we tried to decide, are we working with the same definitions and terms? Because maybe we need to tweak things a little bit, or maybe they've already internalized a concept and we don't need to adapt the curriculum at all. So, yeah, so then we drafted an adapted initiative. So we took important differences, we made little tweaks, and the important thing is that you track all of the adaptations and that you kind of make a list of why. Because later, if you get new information, you can go back and say, you know what, maybe that adaptation shouldn't have happened. Or another instructor can take your work and go back and make the decision that whatever you based your adaptation on was maybe based on not the best data. Because we all know that qualitative, quantitative data, especially at a single site, you're working with limitations. So one of the things that Dr. Chopra and I did was that we decided to take the trainers that were going to be training in TeamSTEPPS, and we brought them all in, and we gave them a TeamSTEPPS curriculum that had some basic adaptations, but then after every single step, we talked about what here was useful for you. What do you think doesn't make sense? What do you not like? Was anything triggering to you? And we got this group of highly engaged people that wanted to be the trainers to give us a lot of feedback, and then that started informing our next process of the adaptation.
Yes, and like Dr. Rice had mentioned, this is a very circular process, in that you do an adaptation or you do a pilot, and then you take all of the incredible feedback you get and make changes. But then you have to go back and repilot what you had just initially done with the new changes. So it takes a lot of time, so you have to be, open to allowing for all of this feedback to come in different ways, and then revise your initial strategies before you do widespread dissemination. So for us, targeting, a small group of stakeholders within the department, and then also using that time to train them, gave us a lot of valuable feedback, because they had the highest interest in this succeeding within their department, so they were very invested in giving us a lot of that feedback.
They gave us a lot of grace.
Yeah.
Yeah. Yep. And then you got your final content adaptation and trial, and this is where you take everything that you've learned, and this is when you really do kind of your first rollout. So we had our Train the Trainer program, which was also part of our curriculum building. That was part of our methodology. But then we did our trial. And this is, we did a pilot, then we did a trial, and then we even did a phase after that. So we did that final trial with the learners. So here, I'm just going to say, if any of you ever do any of these things, remember to disseminate. I haven't published what we did yet. The pandemic got a little bit in the way of it. But if you do the adaptation, I think this is very valuable, because then other people in the region can take what you did and build off of it. And then then on the next slide, I just wanted to show you, again, so we gathered all this data, and then you can see me up there with our group of trainers. Then we had the trainers do a pilot, and we actually used the stakeholders in the hospital. So all the managers and everybody that wanted this, we then brought them in so that they could even give us more feedback, so that this was going to be more widely accepted, because now they got to be a part of it as well. And then by the end of it, you see up there one of the trainers giving these full-fledged curricula, where either myself or Eisha was just kind of on the side to help them out if they needed some support. So that's what we did. And if anybody has any questions, if any of the four of you that came in, thank you so much for watching me slow jam into this mic for 20 minutes.
Do you guys have any questions about anything?
Any questions? And if these are our emails, feel free to contact us. And if you're doing any work in the area, we always love collaborators. Thank you.
All right. Thank you, guys.